Hi, good evening, everyone, all distinguished faculties, honored guests, and organizers. It's my pleasure to welcome you all to this lung cancer webinar. Lung cancer continues to be one of the most significant challenges in oncology worldwide, accounting for a substantial burden of mortality and morbidity. However, we are also witnessing an unprecedented era of progress driven by advances in early detection, molecular diagnostics, targeted therapies, immunotherapy, and multidisciplinary patient care. This webinar will provide an important platform for exchange of scientific knowledge, clinical experience, and innovative ideas that can help improve outcomes of our patients. Over the course of today's session, we will explore the latest developments in the lung cancer prevention, diagnosis, treatment, and survivorship, while fostering collaboration among clinicians and healthcare stakeholders. I would like to express my sincere gratitude to all the organizers and all the faculties who have given time to join us. I wish a productive and engaging, intellectually stimulating webinar. Thank you for joining us. And it was a long time I was having a discussion with the Astra team to engage all ESI doctors in one platform. And thanks all doctors from AIMS who have joined us. And now I request to kindly start the program. Thank you.
Uh, Thank you, sir. Now I would like to move on and I would like to invite Dr. Mridul Khanna, Assistant Professor, Department of Medical Oncology, AIMS, Bilaspur. He would speak on the topic Missed Opportunities, Identifying Lung Cancer Earlier. Over to you, sir.
Uh, Good evening to one and all. I thank the organizers for giving me the opportunity to present such an important topic in India, more so because we, in our practice, in overall, wherever I have served, in our three cancer centers I have served, in India, mostly patients are coming with a lot of symptomatic burden. So the topic that has been given to me is of becomes more so of greater significance. So we'll be discussing about the missed opportunities in identifying lung cancer earlier. Next slide, please. So what we will be discussing today is what is the epidemiology worldwide and the prevalence in India. Very briefly, I'll be touching about the symptoms, the stage-wise survival data, the importance of a multidisciplinary team, and what a stage shift in lung cancer means to us. And the point number 7, 8, 9, 10, we will be discussing more so in detail. That is about the screening in lung cancer, role of AI in screening and early diagnosis. What are the current guidelines, and what are the recommendations for the for a referral pathway? Next slide, please. So, according to the Globocan data, now we have worldwide around 2 million people diagnosed with lung cancer each year, and it is the overall it is the most common cancer and also the leading cause of death worldwide. In India also, although it is the commonest cancer, the fallacy becomes the quality of the data, the cancer statistics that we have. Moreover, we have various sites of head and neck cancer have been taken separately in Indian data, but nonetheless, it is fairly prevalent. Even in we observe that in day-to-day practice, it is fairly prevalent. Almost 3% of the world's new lung cancer cases and 3.7% of deaths occurred in India in 2020, and it has demonstrated an increasing trend also in Indian women, with the prevalence increasing from 7.9 to 27.2%. The problem becomes that only 1 out of 5 people diagnosed are alive at the end of 5 years of diagnosis. Next slide, please. So this is the very important slide. As I have mentioned, that most of our patients that we see are in advanced stage. Mostly we are seeing in India. This is Indian data. around 66% of patients that we are seeing are in stage 4, and only a dismal less than 5% of patients that we are seeing are in stage 1 to 2 are in stage 1 to 2. I have really seen patients with operable lung cancers in my DM, and this needs to improve. So the this slide is also showing the 5-year survival rate, which is remains poor at 9.6%, and the bar graphs, which are again which they are showing the overall disease burden in various stages, mostly are having metastasis. Next slide, please. So we all know what are the common symptoms. I'll just be naming cough, wheezing, recurrent chest infections, shortness of breath, chest pain, etc. These are the symptoms which tell that the disease is localized to the lung. Next slide, please. And these symptoms differ depending whether the disease has spread beyond the lung or not. So, if the disease has metastasized to other parts of the lung, we'll have headache, we'll have bone pain such as back pain, we'll have weight loss, fatigue, neurological symptoms, jaundice, etc. So, next slide, please. So in this bar graph, in the right bottom bar graph, we can see that how the survival 5 years survival outcomes change with change in stage. So we see that earlier the stage, the more is the chances of 5-year overall survival, with stage 1B showing a 5-year overall survival of around 68%, with stage 4A showing a 5-year overall survival of 10%. So the 5-year survival rate in stage 1 is up to 92% compared with stage 2, which is showing up to 60%, and only 10% in stage 4. In India, only around 7% of patients are diagnosed. We saw in the previous slide are diagnosed at an early stage, and most of the patients are diagnosed at an advanced stage. The rest all is covered that early stages have a better prognosis. Next slide, please. So, in managing lung cancer, the multidisciplinary team is required. It starts from recognizing the symptoms by a general physician, the recognizing the initial findings by radiologist, having a good pathologist, including a molecular pathologist. Us, our sister departments such as surgical oncology, radiation oncology. Initially, we all also require help from a pulmonologist, and in patients with advanced disease, we also need a help from palliative healthcare team. In India, 80% of our patients with lung cancer will consult their general practitioner despite their respiratory symptoms. Rarely do they come to us upfront. They are mostly referred to us. And we have time and again seen in various slides that timely diagnosis remains crucial. Next slide, please. So, as we all know, we need a clinical, after having an adequate amount of suspicion or on the basis of symptoms, we need a evaluation in the form of imaging. On the basis of imaging, we then do a biopsy, we do a diagnosis and staging. Now, look at the top left corner of this slide. What we will be discussing subsequently in the next few minutes is the importance of screening, the lack of guidelines in Indian setting herewith. Uh, how screening might help even in our settings, and how it can change. It might downstage. We can see patients with lower stage with the help of screening. So this is an example of a breast cancer, that how screening with the help of screening, how in early 1980s, with less than 50% of patients undergoing screening, how few patients in early 90s. Look at the left, the lower graph, which was showing the breast cancer incidence. So the most of the patients at that time, we were seeing very few patients in early stage. The blue line is the early stage, red line is the red stage. So, with the advent of screening, as the number of patients in the bar graph, the proportion of female patients who were undergoing screening, they started to undergo screening. We started to catch the cancer earlier. And we all know how important, especially most common hormone positive is the etiology, how it drastically changes the survival outcomes even in breast. So mm, after seeing both these graphs, we acknowledge that both cancer have different pathological characteristics, presentation and management. Next slide, please. So we are we have discussed. I opened my slide with this comment only that rarely are we seeing patients with early stage, and this remains our goal. We have, as oncologists practicing in India, this remains our goal, that how to have how to stage shift the patient. That is how to practice in oncology setting, how to bring patients to an earlier setting so that it changes their overall survival outcomes. Next setting, please. Next slide, please. So what are the ideas? How do we achieve this stage shift? So we have to, obviously, we have to increase the early diagnosis. We have to improve the referral by a general physician. We have to have a strong collaboration with the pulmonologist. As I've seen, we can um, have an improved screening outcomes as per the Western literature. We can try and mimic those. We can have some literature. We have some literature from India. We can have further literature from India, and solitary pulmonary nodules follow-up and management. If it improves, then we can obviously increase the early diagnosis. So, what are the barriers to lung cancer screening from the patient perspective? First of all, they are not in the currently not in the national guidelines which have been prescribed. That's pretty obvious. From the other from the provider perspective, there is lack of awareness. There is unfamiliarity with the guidelines, with the Western literature, with identifying eligible patients. We have the Western literature has relatively is common, means a patient more than 50 years with a smoke pack index of more than 200 will should have screening. So they are very consistent on that. So identifying eligible patients, there is lack of infrastructure. We might not be able to with such our, for example, our radiology department. If a patient with symptoms, I'm not speaking about screening, I write a CT today, he'll get a CT in after 6 weeks. So there is lack of infrastructure in our country, and there is with such a high burden of other infections, sometimes uh, the needle of suspicion towards malignancy remains low. From the patient perspective, there is lack of awareness, there is access challenge. Many of the patients are not able to reach tertiary care centers on time. There are cost concerns, and there are perceptions of there is a fear and stigma regarding a malignancy diagnosis. Uh, so we have there have been many there have been regarding lung cancer screening. We have American literature, also we have European literature. We have meta-analysis level of data in terms of lung cancer screening, and those literature have established that if we screen around 100 patients, we will prevent a single lung cancer death. So this is, we have this Western literature. So, and these literature have focused more on patients who were smokers. So what has happened in Taiwan is, so in Taiwan they realized that many of the patients that they were seeing were non-smokers. So they uh, planned a study named Talent Study, which is Taiwan Lung Cancer Screening for Never Smoker Trial. So they also included patients who were never smokers, and with one of these risk factors, whether the patient has family history of lung cancer, first, second, third degree relatives, or includes passive smoking exposure was included. Cooking index by 100. This is 2 by 7 into number of frying days into number of cooking days, and not using ventilator during cooking. These were the risk factors, and around 12,000 patients. So the Western have more, the meta-analysis has had around the meta-analysis done on the basis of eight RCTs had around 80,000 data. So in this Asian study, we have around 12,000 patients, and they are around the sensitivity. The patients who were positive on low dose CT was 17.4%. In Western literature, the sensitivity is hovering around 93% with specificity, which is a very big problem. Specificity is around mid 70%. So 2.6%, around out of 12,000, 11 patients, 311 were diagnosed, around 2.6% was diagnosed. And these were the in the meta-analysis that I have been repeatedly telling about. So these were the major two RCTs which were included: the American NLST, which has around 50,000 patients, and the Dutch Nelson study, which has around 12,000 patients. So the lung cancer detection rate was higher as compared to the Western literature. And as we are seeing that lung cancer now, around 3.2% of patients had a positive family history, with first degree being around 3.3%, having relatives in having first degree relative 1.6%, second and 1.7 degree, third degree. So we all know that patients with the common mutation that we see, EGFR, TP53, have some genetic predisposition also. This was again proven with this talent study. Next slide, please. So, regarding this, if not low dose CT scan, what can be done? So, we can intrapulmonary nodule detection and management need to be done. So, what is incidental lung nodule? What we have to has to be done is that within an institution, whatever we find some kind of patients, and we see some kind of daily reports and patient with on the basis of whether the patient is in a trial or not. Any patient with a suspicious pulmonary nodule, or the patient's electronic records were extracted, and the patient was, on the basis of the current guidelines, he went into the nodule detection, whether the patient needs a biopsy or not, and that may be also applied in the real world setting. Next slide, please.
Sir, sorry to interrupt, but due to want of time, requesting you to please.
Okay.
Yes.
Sorry, I'll be quicker. So moving on. So the majority of lung nodules are incidentally detected. So in a study, around 62% of lung nodules were detected incidentally on the thoracic CT for. So incidentally detecting nodules are that patient, irrespective of symptoms, that they might not be having symptoms exactly of CA lung only. They might be due to some other attributable causes. And in these also, these patients might be again advised low dose CT scan, the annual low dose CT scanning, as per the current guidelines by certain Western groups. So, out of the 70,000 patients with incidental lung nodule findings prior to the implementation of low dose CT, around 44% were never smokers. This is a very big number. Next slide, please. So now we have three methods. Either we can screen the patients via low dose CT, the program-based management of incidental lung nodules that I have mentioned, and no program. That is the multidisciplinary team care, that diagram that we shared in the initial part of slide. So this was this is a deluge study, lung cancer diagnosed through screening lung nodule and neither program. Deluge in the Mississippi data cohort. So in this, what it was found was that only 54% of around 1,900 patients who were deemed eligible for low dose CT by USPSTF 2024 criteria were seen. And look at this table, which is on the left side of our screen. So in these three programs, that is low dose CT versus IPN versus this. So the conclusion of this study was that the low dose CT program and this IPN program were complementing each other. These both of these programs are expanding access to early lung cancer detection and curative treatment, and both may be implemented for early lung cancer screening. Next slide, please. I've spoken about this. Thank you. So this is also I've spoken about that. What is basically incidental lung nodule program is that within the institution or outpatient care, that the list of cases are generated by a data manager, and patients with incidental nodule are extracted from electronic database. And reason is obviously noted. What is the reason? And based on the risk assessment, the clinical and diagnostic evaluation of nodules is done. So various guidelines are using various definitions of suspicious nodule. Basically, any non-calcified nodule more than 4 in our daily practice, yeah, in most of our oncologists are taking as suspicious nodules. Either they are subjected to repeat CT or biopsy. Next slide, please. So now AI it is the agendation of AI is there are more than 50 publications on artificial intelligence in lung cancer. There was one publication from UK in April 2025. I actually went through it. And next slide, please. Next slide, please. It is AI may augment our overall goal of catching lung cancer early, whether through a low dose CT program or whether through IPN, whatever be the methodology, it might augment us. So, uh, uh, can a chest X-ray help detect IPN? So, on the basis of the meta-analysis or the Nelson data that I have been speaking about, so the sensitivity of CT is more so, but data is telling that around 90% of lung cancer is being missed on chest X-ray also. AI is helping. The next slide will show how much the sensitive is AI in terms of as compared to a normal human being. Is 50 plus index journal we have told. And incidental pulmonary nodules will be detected earlier on chest X-ray with the help of AI. So in this, we are seeing the X is the true positivity rate as seen by a radiologist, and blue and red are the various algorithms, the AI algorithms which are being shown. So it is or the true positivity rate of as we can see, the AUC in these curves is very much which can be implemented in our daily practice, especially for nodules and opacities. It is slightly less for hilar prominence as compared, but it is especially for nodules, it is as may implement it in our daily practice. Next slide, please.
Sir, apologies, but requesting you to please conclude, sir, due to time.
Okay, so I'll be yeah, concluding. So, what we have discussed is basically we in India, especially what was in our next slide is basically in India due to the burden of TB, we are missing many lung cancer diagnosis and getting in later stages. So, and that we do not have a in 2016 Ministry of Health and Family Welfare, we did not have guidelines for any lung cancer screening as published in 2016. So finally, we have the NCCN lung cancer screening guidelines and other. There are various societies that we all know in West that they're basically consistent with any age of less than more than 50 years with more than 20 pack years of smoking should be screened for lung cancer with yearly low dose CT scans, and we should have a referral pathway. And can we go on to the second last slide, please? Just that algorithm is something we should not be missing. So we have to have identify some red flag symptoms. Uh, and in the presence of red flags, is if the patient is having severe persistent hemopsis, we have to subject them to PET-CT, ultrasound, or EBUS TB, and a rapid referral pathway has to be done, and via pulmonologist. And we have how to identify high risk of malignancy is shown a patient of age more than 40 years with a smoking history of more than 20 pack years, and non-smokers the risk factors are shown in non-smokers. In this particular pathway via pulmonologist, a low dose CT should be done rapidly, and diagnosis has to be established. In case of low risk of malignancy, we might skip due to the dearth of time. Last slide, please. So, early detection and optimal management of lung cancer are instrumental in strengthening the robust cancer care. There is an unmet need to decrease the lag period from symptom onset to initiation. And achieving early diagnosis of lung cancer requires the general physicians to maintain high level of suspicion, and consultation with a multidisciplinary team at the emergence of red flags could be key to providing a timely and accurate diagnosis. I would like to thank my take-home message is we have to find ways to catch lung cancer early at earlier stage. And I would at the end I would like to thank. I apologize for taking a lot of time. At the end, I would like to thank the organizers once again.
Thank you so much, sir. Uh, Moving forward, now I would like to invite Dr. Leela Rani, Professor, Department of Pathology, ESIC Hyderabad, and ma'am would speak on the topic EGFR biomarker testing in NSCLC, bridging diagnostic gaps. Over to you, ma'am.
Yeah. Thank you. Good evening to everyone. I thank the organizers for this opportunity. My topic for discussion today is EGFR biomarker testing in non-small cell lung cancers, bridging diagnostic gaps. And the content of this topic is on these evaluation, the patient journey and sample, what are the biomarker tests we are doing, EGFR prevalence, and what are the pre-analytical aspects to focus on. Moving on. Coming to the evaluation of lung cancer, sir already has discussed. Non-small cell lung cancers account for 75 to 80% of all the lung carcinomas. And most of them are like 35 to 40% are about adenocarcinomas, followed by squamous cell carcinomas. And this histologic breakdown has paved the pathway for molecular classification in now, only to cater to the very target-specific therapies now, like mutation-specific target regimens have started. So this molecular classification is based on those treatment regimens or targeted treatment regimens. So what are all the next? So this non-small cell lung cancer is a very heterogeneous disease, and it results from mutations or alterations in a wide range of different genes. And these changes are referred to as single oncogenic drivers. So in adenocarcinomas, what we see are mostly EGFR mutations and also KRAS mutations, 25 to 30%. But EGFR mutations are more common we see in young population, in women, and this epidemiological profile in India also is quite different from Western population, is that this adenocarcinoma is more common in women, young adults, and non-smokers. Whereas KRAS mutations you will see more commonly in smokers. So why are we doing this biomarker testing in lung cancers? So this biomarker testing is increasingly used to guide treatment decisions, and we have to identify patients who will likely to respond to these targeted therapies and immunotherapies, and how to increase their overall survival. And what tests are we doing for getting to know these biomarkers? We can use PCR, we can use FISH, we use immunohistochemistry. And the latest now to join this bandwagon is NGS, which allows complete genomic sequencing. So we even get the rare mutations in NGS. In our institute, we are doing PCR and IHC for all the biomarkers. So what are the actionable biomarkers in non-small cell lung cancers? We have EGFR mutations, ALK rearrangements, ROS1 rearrangements, BRAF, KRAS, PDL1 expression, MET, RET, and HER2 also. In our institute, we are doing EGFR and BRAF by PCR using COBAS 4800. And ALK, ROS1, and HER2 and PDL1, we are using immunohistochemistry using Ventana benchmark machine, which is totally automated. So these are the actionable biomarkers for non-small cell lung cancers. And coming to major topic today is about EGFR prevalence and what is the algorithm for testing. So this is the tissue journey from the sample collection, from the radiologist, surgeon, and physician to the lab, and then what is the report given by the pathologist or whatever the molecular markers are. So IHC and molecular testing is a critical component in this diagnostic process. This will help us to personalize therapeutic options for that particular patient, which will improve any clinical outcome, especially in advanced cases. So EGFR mutations are the most common identified in adenocarcinomas. As you can see in that the big chunk of green is the EGFR mutations. The blue is 25% is KRAS mutations, 36% no mutation is detected. The less common ones are ALK, ROS1. In ROS1 is about 1 to 2% in our institute. BRAF, even PIK3CA is done for squamous cell carcinomas. It is seen in those squamous cell carcinomas. So this is the incidence. Can you go back, please? This is the mutation frequency in patients with NSCLC in every country. But as you can see in all countries, the Asian population has more prevalence of EGFR mutations. You see it is highest in cases of Hong Kong and Philippines. In India, in Japan also 26 to 40%. It is 25 to 40% in India. So it is more compared to the Western population, the Asian population has more prevalence of EGFR mutations. So we have to focus more on molecular testing for this. So this is the algorithm. So when there is a diagnosis on histology, we can go for the same biopsy can be usually sent from our institute from the radiology CT guided biopsy. The tissue comes to the pathology department, and when pathologist is finished with their histopathological diagnosis, the same tissue comes to us for molecular testing and IHC. And when EGFR detection testing is inadequate due to inadequate, if it is invalid due to inadequate tissue, we can also go for plasma circulating DNA sample mutation testing, but that is complementary but not totally reliable. We'll discuss in later slides why. So if mutation is detected, the patient can go for a TKI therapy. If not detected, the routine whatever treatment is can be given. And next slide. So this liquid biopsy is a complement or alternative to tissue biopsy, but negative will tests are non-informative. But you may have to repeat the tissue biopsy in cases of negative results. It is highly specific but less sensitive than tissue testing. But there's always a risk of false negative results in case of circulating tissue DNAs. This can only be advised where the biopsy is limited or the patient is not willing for a repeat biopsy or whatever the reasons. But it is not a completely reliable test. But if it is a positive result, it is well and good. But negative results can have to be concluded with a repeat biopsy. So what are the pre-analytical aspects for successful biomarker testing? Before that, I also want to stress on what are all the EGFR mutations we are seeing. EGFR is actually it's an epidermal growth factor receptor. It's a transmembrane protein which has a kinase activity. This kinase activity will regulate the cell's function, division, and cell survival also. So once there is a mutation in this EGFR protein, the mutations will increase this kinase activity and help in more cell proliferation and survival, thus promoting the oncogenic process. So that's why TKI inhibitors, that is tyrosine kinase inhibitors, are used in therapy to check this EGFR kinase activity. So EGFR mutations we look for are in our COBAS 4800 are we look for either they can be insertions or deletion or a substitution mutation. So we look for these mutations in exon 18, 19, 20, and 21. In the most common, we see are 19 deletions and 20 showing PL858R substitution mutation. So these two account for almost 85% of all the EGFR mutations, and they are very responsive to the TKI therapies. But there is after therapy also, there is a kind of resistance mutation that develops in certain patients. And this is a T790M mutation that also is detected by our COBAS 4800. So we can detect if there is a resistant to treatment, we can go for this resistant mutation testing. And that also helps the patients in resistant cases. So coming to the different phases of this biomarker testing, we have pre-analytical, analytical, and post-analytical phases. The more errors happen in this pre-analytical phase, that deals with mostly the tissue specimen handling, transportation, preparation, and storage. And one of the most important factor is insufficient quantity or quality of the tissue in cases of pre-analytical. Then coming to this details of what happens in this analytical errors is, next slide, please. So first is sample collection and stabilization. So 60 to 75% of all errors happen in this pre-analytical phase. So I would tell all the radiologists or surgeons who are taking the biopsy to please take care of, you have to take the biopsy from that particular tumor tissue. Tumor tissue, the amount of tumor tissue present is very important to get a good molecular result in a molecular test, because the amount of DNA detected, the limit of detection is very low, of course. 10 nanograms per microliter is 10 nanograms of DNA is enough for the EGFR testing. But still, if you take the specimen from the right tissue, that is more important. The amount of tissue, at least 10% of tumor tissue should be present in that biopsy. What happens in most routine cases is the tissue goes first to histopathology department, and by the time the same block comes to the molecular department for IHC and EGFR testing, it is exhausted. So we have very little DNA left for analysis. So please make sure that you at least you have 2 biopsies, and one sent for histopathology separately, one for IHC and molecular separately would be very ideal to maximize our results, and that's the best way to do it. But even though I'm stressing, most times it is not happening. So sample quantity and quality is very important. Minimum amount of tumor tissue should be present. Otherwise, the test will come as invalid or no mutation detected most of the time. And also we have to remember that while taking, after the removal of tissue, after the biopsy is done, there is something called cold ischemia time. That has to be less than 1 hour, because you have to, after removing the tissue from the body, to keep the DNA and RNA well preserved. The nucleic acid are very degraded very easily. So you have to place them in formalin as early as possible. And the amount of time ideally should be less than 1 hour. And the amount of formalin also should be more, so that the entire tissue floats in that formalin. So that, next slide, please. So that is what we call as cold ischemia time. So these are the pre-analytical variables we have to follow. So because there are a lot of oncologists and surgeons here, I'm stressing on those facts. And that cold ischemia time is important. And transporting the specimen, it shouldn't be in a very high temperature. 15 to 30 degrees or room temperature is fine to transport the sample. The volume of specimen or the volume of formalin it is inserted also, it should be immersed in formalin. And it should be a good quality, 10% neutral buffered formalin should be used. And we also have various problems in pre-analytical mode, like the quality of the processing fluids, Even the paraffin quality also makes a difference for results. Even paraffin wax temperature at which it melts, it should be ideally at 60 degrees centigrade. So even that makes a difference. So we have to use quality process of fluids and paraffin also for better results. And section cutting should be good. It should be 4 to 5 microns thick sections. And appropriate storage is also important, and appropriate mode of transport at particular temperatures, like room temperature is fine. This with the complete requisition form, that of course we always stress. So all these pre-analytical variables need to be standardized and controlled for a successful molecular test. Next. So these are the various handling and processing practices which have been recommended by a panel of Indian experts. So you can look into that. So the take-home message is lung cancer is not one disease anymore. It's a molecularly heterogeneous disease, and a multidisciplinary process is required to navigate this tissue journey. And NCCN guidelines recommend biomarker testing for eligible patients to determine appropriate treatment options. Liquid biopsy may be a complement, but not totally alternate to tissue biopsy. And negative should also be confirmed with tissue biopsy. So the accuracy of biomarker testing can be compromised if the quality of specimen is impaired by inappropriate processing, handling, or inadequate sample, or bad quality of the specimen. Okay, that's all for my talk. I'm open to any questions. Thank you.
Thank you so much, ma'am. Due to want of time, we'll just move on with the next talk.
Yeah. Okay.
Yes, ma'am. Now I would like to invite Dr. Akhil Kapoor, a medical oncologist, Tata Memorial Center from Varanasi. So over to you.
Thank you. So definitely, in the interest of time, I will continue to discuss about the first line management of EGFR mutant metastatic NSCLC. So we have seen from the previous talk that EGFR is a very important mutation for us. And definitely the Western data is to the tune of 20 to 25%, but Indian data and South Asian data is going towards 40% and beyond. Even one institute from India reported 45% incidence of EGFR mutations. And definitely what is important with the broad use of broad panel NGS, the detection rate of uncommon EGFR mutations also increases, especially EGFR exon 20 insertion mutations. So this is the data. Exon 18 constitutes 5%, 19 constitutes close to 52%, while exon 21, which is second most common, is close to 27%. Now, what is the problem with single agent TKIs? The outcomes are not so good, and we have seen the data to the best with the osimertinib FLORA data, 19 months, but the OS also good with single agent osimertinib, but not going beyond 38 months. So we need something better, and that is why the era of combination treatment came into picture. And with the data, previous data which has shown that FLORA data has shown that already that osimertinib is the standard of care. There's no doubt about it. Now, moving further ahead, why there is a need of combination? The problem is that very few patients can remain on therapy after 2 years. And median PFS is 18 months, as we discussed. In fact, with EGFR exon 21, the median PFS is just 12 to 13 months, in fact, and that is not acceptable in today's era of precision oncology, where EGFR is the most common mutation with us. And definitely we need to do much better. That is why there is need of combination treatment. In fact, before OC plus chemotherapy data came into picture, JEF plus chemotherapy data from TMH came, and it established that chemotherapy will improve the outcomes with gefitinib, and median PFS reached just close to osimertinib, close to 16 to 17 months with the combination of chemotherapy and gefitinib. But the problem was that the treatment combination leads to more toxicity. At the same time, the disease progression in brain is much more common with non-osimertinib treatments, because osimertinib has good cranial penetration. That is why it was expected. when OC plus chemo data came first time, it became very, very important. And we have seen the combination EGFR TKI and other data, NEJ009 data, TMS data, and OPAL phase 2 data, which have already shown improvement in the outcomes. So this is the FLORA-2 design, osimertinib plus chemotherapy, pemetrexed, cisplatin or carboplatin. Most of the patients utilized carboplatin. Osimertinib plus pemetrexed maintenance. This was done. And this was randomized 1:1 trial with osimertinib alone. And a primary endpoint was PFS by investigator assessed. And also there were multiple secondary analysis. It was for exon 19 and 21 patients. Patients with stable CNS metastasis were allowed. So this is the baseline characteristic data. 40% patients had CNS metastasis. This is an established feature in EGFR mutations. And if you see the FLORA-2 PFS, yes, it was improved from 17 months to close to 25 months and a half. And PFS by blinded central review, that also improved from 20 to close to 30 months. So yes, we see close to 10 months improvement overall by adding chemotherapy in the first line settings. If we do subgroup analysis, most of the subgroups are having significant benefit. In fact, all the groups are having a diamond towards the left. That means the drug is effective irrespective of the various subgroups, including brain mets, including EGFR type, exon mutation type, whether it was tested locally, centrally, smoking history. So it is good to know that it is helping not only in exon 19, but also in exon 21, which is much difficult to treat. And you see the outcomes with osimertinib alone is to the tune of 14 months and improved to 21. So a good amount of 10 months around benefit in both exon 19, 21 is expected. If we see, the good point is that with OC plus chemo, there is a CR rate in brain in patients who have brain metastasis. 40% patient had brain metastasis. CR rates was to the tune of 50% with OC plus chemo, and it was just 16% with OC alone. So osimertinib is effective in brain, but chemotherapy is also leading to a significant synergy, leading to significantly improved responses in brain, despite osimertinib having a good intracranial activity. So this is what is important. Sometimes 1 plus 1 is not 2, 1 plus 1 is 3. This is what we are getting in brain. So this is the extra advantage. Overall survival update data is also there now, not only PFS. We have now 10 months improvement in the overall survival, which is a good number. 10 months was the actually previously the overall survival data when the era of NGS was not there and patients were not receiving treatment. So we are adding 10 months OS actually by just adding chemotherapy to osimertinib. So the data is very, very strong. And OS data is also very strong across all the subgroups. So this is an important slide which I want to highlight here. You see, as we discussed, nearly all the subgroups are getting the benefit. It is irrespective of whether it is exon 19 or 21, hazard ratios to the tune of 0.75 in both. Patients with plasma EGFR mutant at ctDNA was positive or not, same difference. Tissue TP 53% or absent, same benefit. Baseline bone metastasis, similar outcomes. Yes, in patients who have baseline liver metastasis, they are getting somewhat more advantage with OC plus chemo. So yes, liver metastasis is a group where the patient do not do very well, and osimertinib alone can lead to poor outcomes in these patients. So hazard ratio in such patients actually improve from overall 0.75 to actually 0.66. And patients who do not have baseline liver metastasis, they are doing somewhat better overall compared to it is 0.83. So this is one of those which is getting extra benefit. All other groups are getting equal benefit, but this group is getting extra benefit. Even in brain metastasis, patients who have brain mets somewhat better benefit, but the quantum benefit in baseline liver mets is much, much stronger. So in this metastasis liver mets, it is getting extra advantage apart from other. Also, we know that in this trial FLORA-2, what happened, median number of maintenance cycles were to the tune of 6 to 8. So, but what is happening after induction chemotherapy for 4 cycles, most of the patients are requiring stoppage of pemetrexed maintenance after 6 to 8 cycles. This is a quite understanding thing because of the fatigue, continuous exposure. A lot of patients are not able to continue pemetrexed maintenance. But what is important, the patients are getting induction therapy and then patients are getting some treatment, maintenance treatment. And after that, patient is on osimertinib alone for significant duration. So though it is called OC plus chemo, a lot of patients after initial induction and then some duration of maintenance are stopping chemotherapy altogether around osimertinib alone. So that is a good point actually, that you gave some induction treatment, some maintenance treatment, and after that treatment was stopped, and the patients are doing much better and doing well even after stoppage of all chemotherapy. So we should not think that OC plus chemo is chemo always, but after some time chemo is actually being stopped due to fatigue and other issues, and patients are doing well. And in fact, next arm subsequent treatment was also chemotherapy, which was platinum-based chemotherapy, because there was significant platinum-free interval actually. So this makes sense. 70% patients received first subsequent treatment as platinum-based chemotherapy. So this is very important. And this is why it is important to know. Also, OC plus chemo, yes, we have experience with JEF plus chemo in a large number of patients. Now, OC plus chemo data is also evolved significantly. So we have found that, yes, OC plus chemo is also a regimen which is tolerated, but it will have slightly increased amount of fatigue, increased amount of anemia, and some initial amount of thrombocytopenia initially. But later on, after induction is completed, the toxicities get improved. So basically, the induction period is a time of higher toxicities, and then it gets reduced over time. This is what we see. Induction period, higher toxicities. Later on, maintenance phase, toxicities get adjusted, and there are minimal grade 3, grade 4 toxicities. There is also data of Mariposa here, AMI plus less versus osimertinib in the first line setting. So this is another option. This is called chemo-free option, though amivantamab is a drug which is a monoclonal antibody but has a significant adverse effects related to EGFR and MET because of bispecificity, and MET adverse effects are more difficult to be adjusted and tolerated. So this study is also a well-planned randomized study of AMI plus LAS versus osimertinib versus lazertinib as a single arm that has already been published in NAGM as well. This is again a study which utilized exon 19 and 21 patients, and again brain metastasis was again 40% in overall patients. The important difference with this trial as compared to the OC plus chemo trial, there was no crossover was allowed. That means the patient who has received AMI plus LAS cannot receive subsequent treatment as osimertinib in progression. So that is an important limitation, and patients who are progressed on osimertinib cannot receive amivantamab actually. So this is one of the very important limitation. Crossover not allowed. So it was expected that OS data will come faster. Yes, the trial was designed that way. Also, hazard ratio, if you see, it is leading to improvement by 7 months, so 16 to 23. If you compare it with the data of OC plus chemo, it is around 10 months, and here it is around 7 months. Subgroup analysis, here the curves are more towards the center. That means AMI plus LAS curves are though better than OC alone. But if you see the subgroups, some subgroups are not getting the desired benefit, while exon 19 is getting a very strong benefit. Patient with brain metastasis and no brain metastasis having both equal benefit. This is a point to consider. So overall data, OS data, it is positive. That is why it is an approved treatment option, and it is leading to hazard ratio of 0.75. And similar outcomes are expected even with data from safety as well. Good point is that now we have learned to manage toxicity of amivantamab, but again, giving it chronically for a longer duration is actually difficult because of multiple toxicities, especially MET inhibitor related toxicities, that is hypoalbuminemia, peripheral edema. But yes, they can be tolerated in patients. Paronychia and rash are other very important problems. But the good point is that there have been very good trials, Skipper trial, Cocoon trial, which have found ways to counteract this. And also subcutaneous amivantamab, which has been Papillon study has come already, which has shown it actually somewhat better than amivantamab alone, or with IV amivantamab, I mean to say. So amivantamab plus lazertinib is a good option, but has its some problems related to logistics, infusion reactions, toxicity management. It is different toxicity than OC plus chemo or JEF plus chemo, and we need to learn about it and to manage it. So some extra specialization and reference with dermatology and are needed. So to summarize, FLORA2 data, this is one of the strongest data available, and we are utilizing it already in a significant number of patients because it is easily available, and we all have utilized JEF plus chemo also in a large number of patients. If you see the Mariposa data, Yes, this is also another option. 7 months of improvement in overall survival and PFS. Yes, definitely these are good options. If you see intracranial efficacy with FLAURA2, it hazard ratio is 0.47, with Mariposa it was 0.79. This is cross-trial comparison. But if you see the curve, it is evident that patients with brain metastasis, they are seeming to be doing much better with OC plus chemo as compared to FLAURA2. Some separation is coming after 2 years with ME plus LAS, and that is also when the number of patients become much less. So it is much less useful to understand, and it is missing the significance margin as well, while it is highly significant. So this is one of the way to select the patients. Patients are doing much better with FLAURA2 in patients with brain mets. Also, as we discussed, there are various subgroups where the outcomes are poorer. These are including liver metastasis, patients with P53 mutations, patient with baseline ctDNA positivity, patient with TP53 co-mutation. These are the groups where the combination is in fact doing much better, and we need to utilize the combination. FLAURA2 is doing somewhat better in some of the subgroups, including patient with brain metastasis. Other groups seem to do similar proportion of 10 versus 7 months as we discussed. So this is again important to understand. IV infusions in FLAURA2 is required every 3 weeks. With AMI, it is initially weekly for 4 weeks, then once in 2 weeks throughout a long time. Toxicity rates are different with different combinations. Infusion rate reductions are higher with AMI plus LAS as understood. Paranoia and these complications are higher with AMI. Rash is much higher with AMI plus LAS. Diarrhea is higher with OC plus chemo combination. And it must be understood neutropenia, which is a common complication of chemotherapy, is much higher with OC plus chemo. So we must understand myelosuppression as expected with chemotherapy will be more, diarrhea slightly more, but other rash, paranoia, infusion reactions are definitely much more with amylase. So we are looking at different toxicities. We need to select accordingly. And OC plus chemo and AMI plus LAS both are approved treatment options, category 1 recommendations. Osimertinib is already there alone as an option. Other options are actually now phasing out. Only good option which we are utilizing till now is JEF plus chemo because of its Indian data and very cheap cost. JEF plus chemo is very single utilized. So now combination treatment is definitely the standard treatment option, and we must utilize these treatment options wherever feasible. Only patients who are very unfit to receive combination start with osimertinib alone and later try to add chemotherapy. That is what we do whenever the performance status improves. And blinded independent central review assessed median PFS with combination reached 30 months, close to 30 months, and median was around 47.5 months. CNS disease control were very significantly improved with OC plus chemo. Also, Mariposa has good data. We need to identify suitable patients when to do what. There is no exact way to select between OC plus chemo versus ME plus LAS, but we must discuss all the options and understand. And also, the subsequent treatment options are problematic post AMI plus LAS. We don't have very good idea about the same. And under second line treatment options are evolving. Dato data is also strong. Dato plus chemotherapy data is also evolving. And AMI single agent is also a suitable option in some time. And we have utilized AMI plus OC beyond progression also in some suitable patients. So all these are the options which we want to understand. Also, a good quality NGS post progression is very, very important so that we can identify subsequent treatment option in a better way in these patients. So I would like to stop here. Thank you for the patient listening.
Thank you so much, sir. Now we'll move on to the panel discussion, and I would like to invite Dr. Aparna Dhar, Senior Director, Hereditary Precision Oncology and Genetic Counseling, Max Super Specialty Hospital, Delhi. And the panel discussion will be on tissue to target, role of MDT in the era of precision oncology. Ma'am, with your permission, I'll also invite the panelists. Dr. Prabhat Ganju, Assistant Professor, Department of Medical Oncology from New Chandigarh, Dr. Amiya Agarwal, Consultant Radiation Oncologist, Navodaya Cancer Hospital, Bhopal, Dr. Vijay Lakshmi Ramshankar, Professor in HOD, Department of Preventive Oncology Research, Cancer Institute, Adyar, and Dr. Arun Kumar Barad, Surgical Oncologist, ESIC, Kalburgi. Over to you, ma'am.
Thank you so much. If it's all right, can you guys present on my behalf just to prevent any technical issues? Would that be okay?
Sure. Just a second.
Yeah. So good evening, everybody. So first of all, thank you, AstraZeneca, for having me here and giving me, it's actually a privilege over here to discuss a topic that I honestly feel is at the heart of our modern cancer care, where we're talking about tissue to target and the role of a multidisciplinary team in the era of precision oncology. And we've seen in the past decade or so a beautiful transformation in oncology, and we've moved from treating cancer. No, first slide, please. We've actually moved from treating these cancers from barely their site of origin, and we are basing them on the molecular drivers. But we know that for every successful journey in precision oncology, it's never the achievement of a single individual. It is actually a journey that begins long before your targeted therapy is prescribed. So you are looking at where the clinician identifies the right patient, the radiologist identifies the right lesion, you're looking at the surgeon or the pulmonologist obtaining the right tissue, the pathologist preserving and selecting that tissue appropriately, and the molecular laboratory generating a reliable result. And finally, the treating oncologist translates all that information into clinical decision-making. So in many ways, what we know is that precision oncology is only as strong as its weakest link. So we know that with all of this, keeping this in mind, yes, next slide, please. What we have today is a beautiful team where we've got everybody in the panel from surgical, radiation, medical, pathology, molecular. And I think to kickstart this, let's get the ball rolling. Let's try and understand, how does it actually function? How does a multidisciplinary team actually function in your particular institutes? Like, do you meet every day? Do you meet once a week? Who drives these tumor boards, and who brings these cases to the tumor boards? And if you do have an error, a problem where you're not reaching an agreement, how do we reach a solution? So let's just kind of get an idea from anybody can kickstart. I'm not going to pick on anyone, but anyone who wants to kickstart with what happens. We're all coming from north, south, east, west. So we're representing Pan India. So, okay, Dr. Amiya, I see you on the video. So let's start with you. What happens in your institute? You're on mute, my dear.
Sorry. Yes, so we meet twice a week for MDT. Each of us, whoever sees the patient first and whoever sort of diagnoses, brings the patient to the MDT, and we have the radiologist, pathologist, medical oncologist, me, and the surgeon in the panel, and we tend to discuss almost 8 to 10 cases in each sitting in our hospital. And if we don't reach a consensus, we usually take whoever has the most
Loudest, strongest
experience.
voice.
Yeah, and that's mostly it.
Right. And is it DMG specific, or is it just Pan?
It's a pen, not specific.
Okay, Dr. Vijay Lakshmi, what happens in Adyar?
Hi, good evening, everybody, and thank you, organizers, for this opportunity. I'm very happy to be a part of this panel. Yeah, so in Adyar, the challenges for an MDT-driven care is there. We still not there. We do have multidisciplinary teams, but it's not this, often meeting and discussing such kind of things don't happen. Or I'm a molecular oncologist, so so therefore, I'm not a part of any of the MDTs which is happening in-house. But yes, for the outside institutes, we do participate in the molecular tumor boards, especially after the advent of NGS, where these reports need to be clarified and discussed, and then we are invited. But in-house, we still have not been able to meet. The MDT dynamics still has to mature in Adyar.
Right. Okay, that's interesting. The molecular oncologist not being there, especially in today's day and age.
Yes.
Okay, let's move on to our surgical medical oncology colleagues. Are they on? Is Dr. Prabhat there? And
I'm here.
Dr.
I'm here.
Arun? Oh, hi. Okay, Dr. Prabhak, what happens with you guys at your end?
So an MDT is usually necessary for every case. So every case, at least we try to do every case through the MDT. We have certain DMG specific MDTs, and the MDT happens every day. But the usual challenge is that there are a lot of cases, and since we try to push every case through an MDT, it takes a lot of time, and so sometimes cases that seem very routine, um, you might miss certain things that you try to rush through them.
Right,
And
right.
so DMG basis, so we have division of cases based on DMG, and surgical oncologists are primary evaluators for certain disease groups, and we are the primary evaluators for the others, and same goes for the radiation oncologists. And so those responsible for the primary evaluation, they bring the case to the MDT. We resolve disagreements there and then itself, at least we try to. Most of them, we try to involve the primary stakeholder for that case, and just if there is some disagreement, we try to bring literature evidence in the next MDT and try to sort it out there and then itself.
So if I may ask, especially in lung, would you see more of newly diagnosed coming into the MDT, or those who have acquired a resistance mutation or who have progressed, since this is predominantly a lung session? What would happen as a medical oncologist? Would you be bringing it on progression or even at a newly diagnosed treatment naive?
I would say most of the patients are treatment naive, because at progression, the role of surgical oncologists and radiation oncologists is very limited.
Right,
And so the decision of tailoring therapy is usually just done by the medical oncologist. So we rarely get it to the MDT. But the important thing here is the MDTs usually don't have a molecular pathologist always there. That would be great to have. And if we would have someone, I think we would want to just do MDTs where we have the molecular pathologist and us along with the radiologist, say. And you don't need to involve the surgical oncologist and radiation oncologist, because they can
right,
concentrate on the other cases where their role is more
right,
important.
right. From surgery, I think we have Dr. Arun, right? Is he here? Thank you, Dr. Prabha.
Yes, ma'am. So in our institute, basically here we do not have medical oncologist in ESIC Kalburgi. So majority of the MDT happen once per week, and usually we have general medicine, general surgery, pulmonologist, and pathologist in the panel. So majority of the cases, as we do not have medical oncologist here, after the discussion and MDT discussion, they get to refer to the nearby centers.
Right, right.
Yeah.
Okay, that's interesting. So I can just, if I could, I know I'm the moderator, but just to give an experience of what we do in our hospital. So we actually run a DMG specific tumor board, and it's usually led by either a medical radiation or surgical oncologist. If we can't reach a consensus, every Friday we run a central tumor board, which is just anything and everything brought to the tumor board. And usually if we haven't reached a consensus, it comes there. For us, we do have our pathologist. For me, the molecular oncology specialist. We do have our radiologists, nuclear medicine, everyone's there. And we also run a molecular tumor board once a week to bring all those rare NGS cases. And we try and bring in experts from, we do a pan-max one, not just one center. But it's again work in progress. And it's exactly what you guys said, right? What we're hearing is that while we'd all love to do it, there are various challenges that do come about. We may not have the expertise. We may have to send it across somewhere else. So yeah, so it's interesting to see that how at the end of the day, there are molecular tumor boards, and they are bringing, or some sort of a multidisciplinary tumor board that is bringing some value to our day-to-day discussions for our patients' treatment. Can we go to the next slide, please? Right, so I think this just kind of highlights what we heard a little bit earlier, that a patient's journey, they do end up seeing multiple people, or the testing goes through, various multiple experts, and that's how we eventually get a report. And it is a collaborative effort. It is a team effort. It's not a one single individual's effort. Next, please. So I want to actually go on to our next slide, please. Okay, so I want to talk about this case where it's a 65-year-old male, non-smoker, comes in diagnosed with adenocarcinoma lung. PD-L1 is 95%, and then on the oncogenic driver here is EGFR exon 19. Next, please. So my question first is going to be to Dr. Prabhat over here. Next slide, please. So in our day-to-day practice, because we get these PD-L1 reports much earlier versus the next generation sequencing, how tempted are you as a medical oncologist to actually start the chemo immuno and then say, okay, when the NGS comes later, we'll figure it out? Or do you wait for the full NGS to come about and then make a treatment decision? What do you do in your real world practice? You've got a patient, let's say performance status 2, patient is symptomatic. What would you do? You have a PD-L1 of this patient, 95%. You have your, do you start chemo IO? Do you wait for NGS? What do you do here?
This is a situation we face actually every day, because
Exactly.
the PDL1 reports usually come somewhere around in 5 to 7 days.
Yeah.
And because we have an in-house NGS, it's the turnaround time is quite long. It takes
Right.
almost 2 to 3 weeks, and depends on batches. If you get smaller batches, might take even longer. So we don't start immunotherapy till we have a driver mutation report, and we are very clear about this. Especially because the main benefit of the initial burden of disease, the reduction is going to be because of the chemotherapy. And there is really no hurry to start immunotherapy, even though you might be tempted by seeing a PDL1 of 90%
Yeah.
and the patient's family also very keen to start. But I think it's very important to make it clear that it's worth waiting for the NGS report, because everything can change.
So when you do NGS, are you doing just tissue? Are you doing liquid? Are you doing complementary testing? And are you just doing basic EGFR, ALK, ROS, BRAF, like 5-7 markers, or are you going beyond that? What does your ideal NGS look like? What are the biomarkers that you cover?
The ideal NGS would be tissue and liquid combined. That is what is recommended, because, as we know, you can miss things in tissue and you can miss things in liquid, and
Yeah.
they complement each other. So ideally would be EGFR, ALK, ROS, BRAF, HER2, NTRK mutation, RET mutation, and
NRG1, maybe. That's a new one.
NRG1. Yeah, I mean, these would be the basic ones that we're really looking for. And obviously, some additional mutations that can, that indicates prognosis. So, like TP53 mutation. So, something like that, that is mainly what we're looking for. And obviously, MET amplification. I might be missing a few here and there, but these are basically there in most of the lung panels.
Right.
And again, complement that with a liquid biopsy. I think that should cover everything.
So I think what I'm hearing is we're moved beyond the usual hotspot panels. We're going to a slightly more wider panel, not a comprehensive one, but at least at baseline, we are establishing by looking at 12, 15 odd important genes that are prognostic, that are therapeutic. Dr. Vijayalakshmi, I'm coming to you. I'll come to you. That are prognostic, like the STK11s, we know that will help us understand from an immunotherapy perspective, the KEEP ones. So I think that's what I'm hearing, that we're kind of doing everything. So moving on from radiation. Yes, Dr. Vijayalakshmi. I think you were to add a comment.
Yeah. So I thought ours is a low resource setting, and I wanted to share what we are doing here that may be useful to the
Yes,
other
please.
centers. So the soon after the diagnosis comes, we immediately do a liquid biopsy based EGFR. Because we are likely, if the patient is a non-smoker or a woman, then immediately we do a ctDNA based EGFR. And if the patient comes positive, then you know that she's EGFR positive and that the target can be started. But then later the biopsy will come. It takes about a week for the sample to reach the lab. And we have two options for NGS from tissue. We do the Illumina-based panel, then that takes about 2 weeks, or it can be a 48-hour NGS on the Amplicon-based. So it depends upon the patient's paying capacity. Suppose if the patient is very sick or something, we immediately give a 48-hour NGS on the tissue. So you have a liquid biopsy based EGFR done, and then immediately you have a 48-hour tissue done on the tissue. So you have the result for the clinician to get started. But it's very easy to do the ctDNA based EGFR, which can be done easily within 48 hours. We'll get a result, something that other centers can also do.
So is it like a ddPCR based or NGS?
Yeah, it's a ddPCR.
Yeah. So Dr. Prabhat, I'm just going to come back here 1 second. How concerned are you about concomitant mutations? So a lot of times we tend to see 2 oncogenic drivers, and the more we tend to do NGS, we tend to see like EGFR coming with ALK, EGFR coming with ROS coming with MET. We tend to see a host of them. How concerned are you about these?
I mean, we do see EGFR with ROS. I've seen one case of EGFR with ALK. Obviously, we're trying to figure out what is the predominant pathway, and I think the WAF can give some sort of an indication of what is going to be predominant. But then, I mean, rarely we've had to treat one type of therapy. We give one type of therapy, say the EGFR therapy, and see if they then progress. If you still have the ALK mutation or whatever the other partner mutation is, and then maybe treat that as a resistant mutation. So, although it's rare, I mean, getting 2 targetable mutations, but still, I mean, we would want to see WAF, and I would want the involvement of the molecular pathologist in this. And I think again here the liquid biopsy can help. So as ma'am was saying that ctDNA, I think that's a good approach. So I've done my DM from Madhyar, and I know when I was used to work there, we had an RT-PCR panel for lung, and now I think we've moved on to this ctDNA. I think it's a good approach. We can save time and save money. At least for EGFR, we'll have a report.
No, absolutely. And I think Dr. Vijay Lakshmi has actually highlighted a real, this is what happens in our clinics. Most of us are coming from a resource setting where everybody cannot even afford testing, or we're in a crisis situation where we need answers quickly. So I think Dr. Vijay Lakshmi has really shown us the right way as to how one should move forward. Next slide, please. So I want to come to the radiation oncologist. We've got, so Dr. Amia, there's a lot of times that there's a lot of studies that show KEAP1 mutations, NFE2L2 are known to be radio resistance. There is some, paper that shows that they can't have any resistance. How much of this are you actually taking into consideration when you're considering radiation therapy? And with these NGS findings, does it really affect the way you think about SBRT with oligoprogression? How do you factor all this NGS into your treatment plan?
Okay, so yes, if the patient has TP53 mutations or any radio-resistant mutations, and I have an account of that, then I do take it into the picture of planning SBRT, because these are radio-resistant, and I would prefer to do some kind of a dose escalation and give more than 100 gray BD dose, which is normally preferred. But I will also take into account the location of the tumor, not go near the no-fly zone. If it's peripheral, I can do like 34 gray single fraction or 54 to 60 gray in 3 fractions. And extreme hyperfractionation is preferred. For oligoprogression cases on TKI, definitely it means that there is some emergence of subclonal resistance while the patient is on a targeted therapy. So what SBRT can do is it can prolong the life of the systemic therapy. We might not need to change systemic therapy right about when we find the progression. There is also a trial which is called the CURB trial. I had worked with Dr. Gillian Sai on this trial and a spin-off of that at Princess Margaret Cancer Center in Toronto. It actually improves PFS by adding SBRT to these cases of oligoprogression by at least 8 months. And we are actually coming up with a CURB TKI trial, which is basically the answer to this question which you're asking. So it will find out all the driver mutant positive lung cancer patients and whether we need to add high dose SBRT or dose escalated SBRT in these settings. And taking into account the mutations, the ctDNA levels, do we need to switch therapy or not? So all these questions will be answered in that trial.
Perfect. Thank you. Can we go to the next slide, please? And I want to actually bring in Dr. Vijay Lakshmi here. Next one, please. There's a case. Can you just go to the next one, which is a case scenario? Perfect. So a lot of times, Dr. Vijayalakshmi, we see that the testing comes, and I'm unfortunately, people like you, me, we're on the receiving end of when that failure comes, and it comes 1 week later, 10 days later. Sometimes we're able to preempt it and tell them. Can you help us understand as to what could be the potential errors that could be happening in the lab right from when we take the sample, the biopsy specimen, and EBA specimen, and FNAC, right from there till the end? And as to, I know we had a wonderful talk from Dr. Leela a little bit earlier, but if you could just kind of walk us through what we all should be careful of in a clinic so we can kind of, take it back to our institutes and tell our people, this is what's to be done. This is the gold standard. So over to you, Dr.
Thank you. So there are very categorical pre-analytical factors that goes into before we accept a sample for NGS. So the NGS activity starts even before the sample actually reaches the lab or the sequencer. The lot of factors which are important, which goes right from the collection of the sample. Now, if you take this particular case scenario, which has been shown here, the EBUS sample has been received. The sample acquisition and fixation has happened on a Friday. And then you're having a Saturday and Sunday in between. And then Monday, the sample has reached the lab for the processing. So if you look at the fixation time here, which is like more than 72 hours. So being a weekend, the sample has been left in the fixator for a longer time, which will be very, very detrimental to the quality of NGS. So there is a high probability of the library failure in these kind of cases. See, from the pathologist perspective, from the lab perspective, the sample has been received nicely in a 10% neutral buffered formalin solution. That is done. Then if you look at the volume of the fixative ratio, that also is good. 20:1 has been maintained nicely. But where we have made a mistake is the fixative time has been more than 72 hours. So this will be very, very detrimental because excessive formalin exposure can cause a lot of DNA fragmentation. And this DNA fragmentation, there is going to be increased DNA cross-linking. And if it is going to be an NGS where you're going to be using RNA also, then there is going to be a lot of RNA degradation. There'll be a reduced yield. And also this can lead to a poorer library preparation. So therefore, this is a very important thing. So the pre-analytical variables are important where the time to fixation, what is the time? And then what is the duration of fixation? Then the tissue handling, how the sample has been handled, the cold ischemia and all that, and it has to be a rapid processing. So these are very, very crucial for a successful NGS.
Thank you. I think you very beautifully summarized it. So I'm going to come back to our medical oncology colleague here, Dr. Prabhat. Dr. Vijayalakshmi has just very, very beautifully explained the do's, the don'ts of how we can ensure we get a good sample. But unfortunately, a lot of times you are on the receiving end when this NGS fails and the patient sits on your head. What would be your takeaway from this? How do you handle this in your clinic with your patients? And what would be your key takeaway from, what's just been discussed?
This is also something that we face routinely, and it becomes very difficult to face patients, especially after the first or even the second time the biopsy or the NGS has failed. So what usually I think ends up happening is till we face these failed NGS processing, we don't really pay attention to how the processing has to be done, how the transportation has to be done. But soon as we come to know, and I always call our molecular pathologist whenever there's a failed sample to ask what went wrong, so that I have a clearer idea about what to do next. And so we kind of did our own audit, and we found out that we had a failure rate of somewhere around 20 to 25%. And we saw that this was something that was similar in most institutes. And I think it depends on at what point the failure is happening, whether it's the fixation that is the problem, or the DNA extraction, or even after the DNA extraction, if there is a failure. So what we tend to do is we'll try to do the DNA extraction and check the quality, and if it's suboptimal, we refund the money there and then itself. and they kind of inform the clinician this is what has happened, so they can inform the patient, and we can start the process of doing either a repeat biopsy or then we do it by RT-PCR if it's possible.
Perfect. And let me just bring in Dr. Arun here. So a lot of times you guys are collecting the sample for us. And I know sometimes in our institute there's this continuous tussle that take proper course, give us extra samples. So do you face something like this? So when these tests start to fail and then suddenly we're like the tissue wasn't enough. How do you deal with this in your practice as a surgeon?
Yeah, here it has happened many times that usually the trainees, training PGs and the senior residents, they take inadequate samples and majority of the times, and here the processing time and overall time to get the report is very huge because in our institute probably it takes around 15 days to get just to get a report of a biopsy. So here majority of the times it has happened like that. So we have created a standard protocol here. So any solid biopsies to be taken will be clinically examined by me, and the point of biopsy to be taken and the which particular, I mean, considering the future incisions, we point out the possible sites of the biopsies, and sometimes if the lesions are having variegated consistency, solid cystic, in those cases we'll try to get ultrasound guided biopsy, and we make sure that minimum 6 proper cores are taken, which are not including the fat, and which usually get sunken whenever the put into the formalin. And nowadays the negative reports, biopsy reports have decreased, but anytime these problems are difficult to fix because the report comes after 15 days, and after 15 days if the pathologist tells us that the sample is inadequate, again go for a biopsy, again 15 days are wasted. So it is very counterproductive, and it is very difficult to explain to the patients, and the overall treatment is delayed.
Thank you so much. So I know we've got less than a minute left. So very quickly, each of you, a key takeaway where you feel that they can bring a difference. So Dr. Vijay Lakshmi, what would be your key thing? Oh, no, go back one slide. Yeah, just leave it here. So how do you think as a molecular oncologist, how would you collaborate over here? What would be your key takeaway? Or what do you think we can do better for our patients?
I think it's going to be it's always multidisciplinary. So we have to have a collaboration here, and each of us have a role. So if you see, there are concrete roles for clinician. When it comes to clinician, always plan the biopsy with NGS in mind. You're going to be giving an NGS in future. So one has to think that, what is going to be. So if you're going to be doing NGS, then you target the most viable lesion for your biopsy, and always order a molecular test early. And if you can consider a liquid biopsy earlier, please do that. So this will help us from the part of the clinicians. And from the part of the pathologist also, there is a role, clear-cut role. One, they have to evaluate the tumor adequacy. And then if needed, if there is a need for a macro dissection, then that has to be done. If the sample is scanty, then if they think that macro dissection can help, they have to enrich the tumor and then send it for NGS. And also, other than that, preserving the tissue, communicating it early. And when it comes to molecular, I think one has to have clear-cut guidelines for acceptance of the sample, and then how you're going. So what is going to be your criteria for acceptance? There has to be what is going to be your tumor content that you will accept, and then DNA concentration and other QC.
Yeah, absolutely.
So everybody has a role.
Perfect. Yeah, sorry, I'm getting here asked to conclude, but thank you. Some very pertinent points. Dr. Amir, very quickly, one line. What would be your key takeaway?
My key takeaway was it will be that we need to do MDT regularly, and we need to give importance to radiation oncologist as well for SBRT because it is giving us good results, and that is what I've learned in Canada. So that's
perfect. Dr. Arun, surgical.
As ma'am has highlighted, it is always a multidisciplinary approach, and there should be often a lot of communication between the pathologist, molecular pathologist, and the surgeon, and the medical oncologist involved, and also as well as radiation oncologist. So it is always a team approach, and it has to be. We should have a proper communication among ourselves for the better care of the patients.
Perfect, Dr. Prabhat.
So I think doing an MDT where the molecular pathologist is involved, the radiologist is involved, the intervention radiologist involved. So we know what challenges each and every one is facing, and so we kind of can come to a consensus. Also, along with that, regular audits of what are
Right.
the failures, the NGS failures, and why they are happening. I think that will go a long way. But other than that, everything else has been covered by. So,
Perfect. So I think the key essence here is that while NGS is very fancy, but actually it really boils down to something which is fundamentally human, which is communication, 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 communication. And that's what benefits our patients the most. So thank you so much, panelists. You guys were phenomenal. Amazing, amazing, comments from everybody. Thank you so much, organizers. I know we've overshot by 2 minutes. And back to you guys. Thank you very much, everyone. Have a good evening. Thank you.
Thank you. Thank you for
Thank
having us.
you. Thank you.
Thank you, ma'am. Now we move on to the next panel. Our moderator is Dr. Pulkit Nag, consultant medical oncologist from Essex Hospital, Jaipur. So with your permission, I would like to invite the panelists also.
Yeah, please go ahead.
The panelists are Dr. Ashish Upadhyay, HOD, Department of Oncology, ESI, PGI, MSR is ESI Medical College, Joka, Kolkata. Dr. Gautam Sarma, Associate Professor, Department of Radiation Oncology, AIMS, Guwahati. Dr. Hemant S. Galgi, Consultant Surgical Oncologist, Essex Medical College and PGI, MSR, Bangalore. Dr. Minit Shah, Associate Professor, Medical Oncology and Hematology, Tata Memorial Center, Mumbai. Over to you, sir.
All right, I'll share the slides.
Okay, sir.
Yeah, I hope it's visible.
Yes, it is, sir. If you can just make it full screen, please.
Yeah, I hope
Done, sir.
I have all the panelists.
Yes, sir.
Okay, so yeah, so a very good evening to Dr. Ashish, Dr. Gautam, Dr. Hemant, and Dr. Minit. Yeah, so we're gonna discuss for next 30 odd minutes about the adjuvant and consolidation strategies in EGFR non-small cell lung cancer with the clinical consideration and the role of TKIs. Hi, Dr. Ashish. Good evening.
Good evening.
Good evening. So, like before starting, do we have a surgical oncologist here? Dr. Hemant? Dr.
Yes,
Hemant,
sir.
are you
Yes, sir.
there?
Yeah,
Yeah,
yes.
yeah. So before starting, I just want to ask you, how frequently do you see resectable lung cancer referred to you in your OPD?
Sir,
How much?
maybe once in 3 months.
Once in a 3 month. Okay. But Dr. Ashish, do you refer or do you see resectable?
No, very rarely. I think once in 6 months.
Once in 6 months. We have Dr. Minit also, Dr. Minit Shah. Your opinion on
Hi,
that?
hi. So
Yeah.
we have quite a few patients whom we see of lung cancer per year, around 2,000 to 2,500. Of them, only 15 to 20% come in this early stage resectable, whom we can consider for the Checkmate 816 or any of the other similar trials.
Okay. And how many of them actually undergo surgery? Like, uh,
Amongst those eligible, 50 to amongst those eligible, only about 50 to 60% eventually end up coming on the surgical table.
okay, okay. Dr. Gautam, your take on it?
Yeah, very rarely we see resectable, mostly like stage 3 coming for chemoradiation.
Okay. And no stage 1, stage 2 patients in your OPD? Dr.
Hello?
Gautam, any stage 1, stage 2 patients commonly do you see?
Very rarely. And patients that we see like uh, stage 1 coming in older age, we go for SBRT.
Okay, 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 perfect. So I think that this is a sponsored session by Astra and the slides are provided by them. So I'll straight away move to the next slide. Yeah, so the first case is a very simple case. A 59-year-old female non-smoker with stage 2A lung adenocarcinoma. I think all the PET scan and biopsy and IHC it is proven. NGS considering it has been done, and patient has EGFR mutated L858R substitution mutation. And there was a MDT discussion, and patient had went
upfront right lower lobectomy. So, what would be the treatment of choice for this patient? Let's start with Dr. Ashish. Yeah.
So, as because this is stage 2 lung cancer, so mostly I'll be going for 4 cycles of adjuvant chemotherapy, followed with osimertinib for 3 years.
Okay, wonderful. First, I'll hear all four and then we'll discuss. Yeah, Dr. Minit, your take.
I agree. So plus minus on the chemotherapy, but the most important backbone is the osimertinib for 3 years. We can debate later about the duration, but yes.
And I think that plus minus is also a major area of debate. We're going to come on that. Dr. Hemant.
Yeah, first we need to do about the complete pathological staging. We need to assess what are the high risk features this patient will be having. Based on that, we'll be considering to do on a tumor board and decide on the chemotherapy. So mostly, usually it will be giving a platinum-based chemotherapy for 4 cycles, and
Okay.
followed by our osimertinib since the EGFR is mutated.
Okay. Dr. Gautam, anything you want to add or same?
Yeah, I used to see like patients receiving chemotherapy followed by TKI, osimertinib. But nowadays I am getting to see patients like directly going straight to osimertinib also.
Okay. Yeah. So that's the point. Dr. Minit, you have said plus minus chemotherapy. So any for any stage 2A patient, you would like to go with chemo followed by osimertinib, or there is a selection criteria per se by you?
So there are a number of factors that we see, especially so in the surg. So firstly, beginning with the surgical specimen, so we can start off with the patient. So the patient has to be fit for 4 cycles of platinum doublet chemotherapy. That is number one. Number two, coming to tumor pathology, presence of poor risk factors on the pathology like LVI, PNI, poorly differentiated adenocarcinoma, presence of STAS. So all of these are some of the poorest features in the histopath. But most importantly, along with an L858R, if there is co-occurring mutations, like if there is PIK3 or CTNNB1 or
Yeah, even
TP53, any of them
TP53. Yeah.
conferring poor prognosis, then definitely I would prefer for chemo followed by. Fourthly, most important, this is an L858R. So we all know that there is a difference between L858R and exon 19
Yes.
deletion. If there was an exon 19 deletion, straight ahead means and no other poorest feature, then osimertinib alone is okay. But I tend in an EGFR L858R to give the entire treatment of chemo followed by osimertinib. And the last thing that I want to say is that the subset analysis, there is not much difference in the hazard ratios, but these are the few points that I take to select chemo followed by osimertinib or osimertinib alone.
Dr. Ashish, anything you want to add on it?
Definitely. Along with that, again, the fitness of the patient is also very important. If the patient is fit enough and if the patient is having node positivity, then definitely I'll go for adjuvant chemotherapy. Otherwise, for node negative patients, all these factors needs to be taken in out.
Okay, perfect, perfect. Yeah, so I think we all agree that in these adjuvant settings, we do have a role of osimertinib. But since now also we have a debate very commonly seen that whether to give osimertinib directly or to give chemo followed by osimertinib. As Dr. Minit has rightly pointed out, that age is an important factor, performance status is an important factor, and all the other things are there. But on the contrary, when we talk about the metastatic lung disease and when the patient performance status is also poor or good, I think we follow the same steps, whether to go with the chemo plus osimertinib or osimertinib alone. So I think that applies in the adjuvant settings as well. Okay, so I think this patient is planned for 3 years of adjuvant osimertinib without adjuvant chemotherapy. So in this patient, no chemo was given. That was the MDT discussion. And we all know about the Aurora trial, and we can see the clear-cut difference in the benefit of DFS if we compare adjuvant osimertinib versus placebo. As you can see on the right-hand side, the Kaplan-Meier curve, that is 85% versus 73% with a significant p-value. So there's other some few points of discussion. I'm going to go quickly. So after surgery, when do you like to start the adjuvant osimertinib? Dr. Ashish.
Within 8 to 10 weeks, if the patient is not receiving chemotherapy, otherwise within 6 months after the completion of chemotherapy.
Okay. Dr. Minit?
No, actually, so if patient is planned for chemo, then fine. If patient is not planned for chemo, then as soon as I get fitness from my surgical colleagues and the stitches are out, I think, and there is no problem for wound healing, then we start off with osimertinib.
Dr. Hemant, I want to know that how oftenly and how frequently that post-operative lung cancer patient recover. Do you find a difficulty in that, or what is the common time period for that recovery?
So, usually the patients who are having lung sparing surgery, like lobectomy, they
Okay.
tend to recover faster, maybe by 3 to 4 weeks.
Hmm.
However, patients with having pneumonectomy for a case, because of either surgical complications or their proximity to the major vessels, if they we have to do a pneumonectomy to achieve R0 resection, then usually because it will have a lot of the mediastinal shift and the ICD will be there for quite a long time. So usually they take almost 6 to 8 weeks for them to do a good performance. So first one, my main concern is the performance because of the mediastinal shift, everything. Second is the wound issue. So many times we
Okay.
find the wound also having non-healing features because of a nutrition issue in the post-operative period, because they may be on a elective ventilation for some time in the post-operative period. So with all the things with the post-operative complications, fairly say, around 8 weeks, patient will be mostly fit even after a lobectomy. For lobectomy, it is 4 weeks, and the pneumonectomy, 6 weeks is the this one.
Okay. Thank you so much. So, Dr. Ashish, for stage 3B case, would you like to prefer, like we all know that the Adora is from stage 1B to stage 3. So if a stage 3B patient comes to you, would you like to go osimertinib beyond 3 years? We already have a trial running on it, checking on the 5 years data. So what are your comments on that?
Basically, I would not be really going for osimertinib beyond 3 years. Another thing which we can be done is ctDNA testing. If the ctDNA is negative and the patient is doing well, then I'll keep osimertinib for future as well, because we know osimertinib is a very good drug and the side effect profile is also very good. It maintains the good quality of life for the patient.
So the next question, Dr. Minith, is do you really do ctDNA frequently in your OPD setting, or you want to wait for the disease to come back again and then restart osimertinib? Because in oncology, the first hit should be the strongest hit. Yeah, your comments on that.
So, frankly, we're not routinely doing ctDNA in the adjuvant setting for when we follow Adora as a practice for a number of reasons. Number one is that the test should be validated enough to pick up this ctDNA at the lowest levels. That is number one. Number two, the same test is preferred to be done over the entire period of surveillance. Thirdly, a log rise or a log fall, I think only increases the anxiety, and we need a much closer follow-up. So I may not be able to act or escalate or de-escalate based on those values. Fourthly, regarding the duration, so what is important is that in the DFS curve, post 36 months, the drop post 36 months is quite a steep drop. So that is why
Yes.
the those who have stopped osimertinib, their number of recurrence events have significantly increased, and that is why the study of 3 versus 5, or maybe even 5
Yeah,
beyond.
the target
So
study. Yeah.
as of today, I am not routinely giving osimertinib beyond 3 years. But after a shared decision with the patient, if they understand, if the patient insists that they want to continue, only then, but not as a routine. I'm continuing beyond 3 years, and I'm not doing ctDNA as a routine in these patients.
So I'll continue with you only, Dr. Minith. Suppose you have given the like if you stop osimertinib at 3 years and the
Yeah,
patient had relapse,
yeah.
then what is your next plan, the investigation and the treatment?
Correct. So, the DFI is important. So, after how many months or years of osimertinib the patient has stopped, and more important than that is what does the next NGS say? So, usually, if there is a short DFI progression, definitely there is some sort of resistance which is developed to osimertinib, and you follow similar protocols as what we would have done in a first line osimertinib setting in the palliative setting. The question would come is, what would we do after if there is a good DFI, like beyond a year, and there is progression? So I think most of the decisions tend towards what is there on the NGS and what is the resistance mechanism. So I think that determines.
If you want
Uh,
to, okay, I'll continue with Dr.
yeah,
Ashish. If you
yeah.
want to re-challenge osimertinib, it's in continuation of what Dr. Minith has said. If you want to re-challenge osimertinib, what should be for you as per the ideal DFI that you want to re-challenge, and which should not be the ideal case in which you like to add chemotherapy? And as Dr. Minith has said about the resistant mutation, So post osimertinib, what exact resistance mutation is going to help you to decide your therapy?
So basically, if you talk about DA5, I would be looking around for say minimum 9 to 12 months of DA5 if the patient is doing good post completion of osimertinib. Even if the patient has completed 3 years of osimertinib and after that the patient has developed say only single metastatic lesions which can be addressed by either surgery or radiation, then along with that maybe another important factor can be osimertinib concentration. And you also asked about the age chemotherapy. Definitely, if the patient is having TP53 mutation, then I'll be adding chemotherapy with osimertinib because we know that prognosis of those patients are not that good with osimertinib alone. And if you talk about the resistant mechanism, definitely repeat biopsies, both solid, liquid, with comprehensive NGS is the way to go. So we do look for subsequent MET mutation. Then HER2 amplification is also there, or we have 4 generation C797S mutations. If that mutation is trans, then many times the combination of osimertinib with first generation TKI also works. Otherwise, we also see histological transformation to small cell carcinoma many times, and also HER2 mutations as well.
Dr. Hemant, I want to see that have you seen any local recurrent patient of lung cancer in which you has the opportunity to advise surgery in the recurrent setting? Dr. Hemant, did you got my question?
No, sir, I'm not able to hear. Yeah.
Okay, so like I was asking you that suppose the patient had surgery and that have received any adjuvant TKI and post after a DFI of 1 to 2 years, patient has only a small local recurrence, and initially you have done only the lobectomy part. So do you have ever advised the surgery in the recurrent setting again? Is there any patient came to you regarding that?
So once again, if there is any recurrence, with either local or distant, we need to again restage the disease and talk to the patient what is the benefit that he's going to receive from a local treatment. So the
Okay.
first priority is to straight be for the systemic therapy, give a challenge of systemic therapy and reassess for doing a local therapy.
Okay. Thank you. Okay. Dr. Gautam,
Yes.
any role of radiation in recurrent settings in this localized patient?
So if this patient has already underwent surgery and then on TK and has some local recurrence, yeah, we'll assess the volume. And if it is possible for us to achieve the lung constants, we'll definitely offer him local therapy with radiation.
Oh, thank you. So I think patient receive osimertinib are most likely to have a DFS and MRD event-free versus placebo. We all are aware of it. And the MRD analysis demonstrated the maintenance even-free status for most patients on osimertinib treatment and was able to know the recurrence prior to the DFS event. So I think we are all aware of this graph. And as we were discussing that beyond 3 years, is there any benefit of 5 years adjuvant osimertinib? So I think the phase 2 target study is still going on. We only have interim results by now, and the full-fledged results are still yet to come, especially in stage 3A, B, and B. These are the most important patients whom, if after neoadjuvant chemo, if we resect, and do we want to continue up to 5 years? What's the data say? Let's wait for the final results. So, continuing with the case study, 6 months later, post Adora, CT was done, and there was a 9 nodule in the posterior right lower lobe of lung. So there was multiple prominent mediastinal lymph node. The patient was asymptomatic. The mediastinal lymph node biopsy confirmed recurrent lung adenocarcinoma with EGFR, L858R mutation and TP53 mutation. Started on osimertinib. So this patient has been re-challenged on osimertinib even after having TP53 mutation. So Dr. Minit, your comments on it. Do you want to add? Suppose patient has received previous chemo. So you want to add second line chemo and then osimertinib? Or what do you want to do?
So this, I think this was just a single 9 lung nodule,
Yeah,
right? So
yeah, yeah.
no, I don't
No,
know.
in
Are we
view of
practicing?
TP53, I'm asking.
Yeah. Uh, See, ideally it does. So the combination of L858R with the TP53 is not a good combination for an EGFR TKI alone. Wouldn't be too comfortable if I do only a TKI, then I will closely monitor. But just to ask for this patient, we have done any no local therapy, right? For this 9 single lung nodule? Any idea?
Nothing.
No,
Nothing.
no. Okay,
No.
okay.
Yeah. Only the biopsy that nodule has been left around, but there was
Hmm.
mediastinal node and pathologically it comes out to be positive. We repeat the solid NGS and we have a EGFR with TP53. Dr. Ashish, your comments on it?
I'll be going with Aussie plus chemo.
Yeah,
Yeah, chemo followed by osimertinib, you want to go.
Yeah.
Okay, okay, okay. So patient was started on osimertinib and patient had a CR to the therapy, and after 2 months of treatment. So I think we have already discussed that when do you want to re-challenge osimertinib? Do you want to give other TKI, chemotherapy, or any VEGF inhibitor? We have already discussed what should be the second line option in the presence of osimertinib acquired resistant mutation. So I think we all agree that if there is any bad mutation is there, then and if previously the chemo is not added, the better to add the chemo and then followed by the adjuvant osimertinib. Perfect. So we'll move ahead with the case two. And I think Dr. Gautam will have to add something in the case two more. So a 63-year-old male with complaint of cough and blood in sputum, 40-year history of smoking. CT chest shows 7.7 into 6 centimeter left upper mediastinum surrounding the left subclavian artery. Obviously, the PET scan was also done. So patient was initial evaluation is chronic bronchitis, emphysema, and pulmonary bulla. Lungs were also observed and the EBUS TBNA was performed. The biopsy specimen of left upper paratracheal node suggestive of poorly differentiated carcinoma. PDL1 was less than 1%. NGS EGFR was positive. It was exon 19 deletion. Brain MRI and bone scan showed no distant metastasis. So the final diagnosis is clinical stage 3B T4N2M0 poorly differentiated lung carcinoma. To make it easy for you, it is adenocarcinoma. So, yeah. So, any further investigation, anything wants to add? Dr. Hemant, anything from your side? Any
So
investigation
usually
you would
for
like to see in this patient?
now PET scan
MRI brain will be required.
Yeah, Dr. Gautam, please go ahead, please. Yeah.
MRI brain will be required, sir, for this patient.
Okay.
Additional investigation.
Okay.
And obviously, like as you said, PET CT, it's not only for like to take up metastasis, but it also helps in radiation planning also. Because
Okay.
otherwise, like it's very difficult to distinguish the tumor and collapsed lung in a CT scan. So nowadays, like every radiation oncologist, they take the PET and they put it in their contouring stations so that only the uptake area we target. And treatment standard is we'll go for chemoradiation, which is the most preferred and standard. If otherwise we are not able to achieve our lung constraints, then we may go for induction chemo followed by concurrent CTRT. But usually it's CTRT that we'll go first.
Okay. Dr. Hemant, you were saying something regarding the
PET scan,
investigation.
as
Yeah.
already sir has emphasized. Along with that,
Yeah.
the PFT also has to be assessed because the lung will be collapsed. It's such a huge
Okay.
thing. So it will be difficult. So PFT also has to be assessed along with all the complete molecular profiling because it's quite a huge tumor as seen in the imaging.
Okay. So, Dr. Ashish, by what stage of lung cancer, NSCLC, would you like to add MRI on the initial staging basis?
From stage 2 above, basically, I go for MRI.
Okay. Okay. So you do with all the patients?
At least I advise for most of the patients. It's not
Okay.
always possible to get MRI for most of the patients. Those patients in which the intent is mostly palliative, where either we have to give radiation or chemotherapy. In those patients, we are going only with PET scan, PET CT scan.
Okay. Dr. Minit, do you check for biomarkers for all stage in patient in NSCLC?
Yeah, so I was going to talk about both aspects. So first is from T1C. So we recommend MRI for all patients. Curative, definitely yes, yes. Our MDT doesn't allow for any curative intent treatment for early stage or stage 3 without an MRI brain. That is a short thing. For palliative setting, also for all patients, we end up doing MRI. That is the first thing. As per guidelines, it's T1C onwards. So T1C onwards, ideally patients should get an MRI brain done. Secondly, we don't know the type of EGFR in this, whether it's exon 19 L858R versus the uncommon, because that will also decide post chemo radiation whether it'll follow the typical LAURA or some other immunotherapy regimen. So we do biomarkers, especially not single gene testing. We do. It's a good part of being in Tata that we have a number of support programs for doing NGS. So we do end up doing NGS for all stages of patients with NSCLC.
The gist is that apart from stage 1A,
Correct.
You're going to do NGS in almost all the patients of upfront de novo NSCLC. Am I right?
Correct.
Yeah. So the third question, I think we all agree that we all are doing comprehensive gene panel, or someone wants to speak about any is free platform, hotspot lung panel. Anyone is doing that? Or we all are doing comprehensive NGS? Yeah, anyone can take it. Yeah.
So we at Tata, our in-house is not a CGP. So our in-house is around a 50-55 gene panel. So we are not doing CGP for all patients. We can always debate on the how many genes are important and the number of genes and the TMB and the MSI, and we can always debate on that. But we are doing an in-house is about 50-55 gene hotspot gene panel. But if you ask me, ideal, it would be tissue plus liquid. CGP would be ideal, and now upcoming thing would be about methylation profiling and all would be a separate topic to discuss. I think anyone else can also take up this question.
Yeah, I think we are done with it. So this is just a important diagram showing we all are aware that what kind of patients are resectable and what are unresectable. And we all know that any N2 bulky disease, and especially in combination with T3 and T4, we call it unresectable. And that is why up to stage 3A and 3B, we call it borderline resectable, depending on the patient condition and other related factors. We all are quite aware of it. So this talking about the case since the tumor is unresectable, then patient underwent one cycle of chemo, and the patient was evaluated by PET scan. The diameter of the mass had increased. The tumor was enlarged in size. Radiation therapy was CTRT was planned. So Dr. Gautam, in your common practice in these kind of patient in stage 3B, do you still think NSCT followed by CTRT is going to help you in preventing radiation-induced toxicity, or you think de novo CTRT is still the treatment of choice?
We go for CTRT first, sir. So
Okay.
only in case we cannot achieve our lung constraint, then only we ask for induction chemo. Otherwise, we
So
go for
any
CTRT.
difference in your contouring planning of the normal OAR if you go with NSCT followed by CTRT or de novo CTRT?
So if this tumor mass or bulky nodes they shrink. So like this mediastinal volume comes down. Otherwise, as such, no much of change.
Okay. Dr. Ashish, NSCT followed by CTRT or de novo CTRT?
So basically, I'll be going for NSCT in this patient. Other factors are also very important. That is the PS of the patient, especially because of the burden of the disease. As we can see, this is a higher mass. A lot of critical structures are there. So I would want to downstage the disease a bit so that radiation, pneumonitis or esophagitis can be decreased a bit.
Dr. Minit?
Yeah, so we'll definitely we would be discussing this in the MDT and with our radiation oncology colleagues. We are more for definitive CTRT rather than any other thing. But considering this patient about with chronic bronchitis, emphysema, bulle, poor lung fields, most of the times we end up doing sequential chemo followed by sequential chemo RT rather than definitive CTRT. But that is on a case-to-case basis. So first, importantly, it's definitive CTRT. If not feasible from our radiation oncology colleagues, then NACT CTRT. And from patient perspective, if not fit enough to tolerate such a definitive CTRT, then it will be sequential chemoradiation.
Okay.
Exactly. I
Dr.
also
Gautam?
agree.
Yeah.
I also agree
Yeah.
to him. Yeah. The same.
Okay. So, Dr. Gautam, you must have seen a lot of lung cancer patients. Any common reasons you want to say for not completing the complete course of CTRT in lung cancer patient?
Sir, mainly the hematological toxicity like febrile neutropenia, then severe radiation esophagitis or severe radiation-induced pneumonitis, or if there is any disease progression.
Okay. And how do you monitor such patients who don't complete CTRT further?
So, like
The last
first,
question.
we will be monitoring them weekly during CTRT with CBCs and metabolic panels and other like clinical symptoms. And like if the patient does not this thing improve, then like we have to stop our treatment, sir.
So, what are the common toxicities you experience, like esophagitis, the nearby structure, or pneumonitis?
Mostly that we encounter is, sir, hematology toxicity more, and then esophagitis.
Okay. So I think this diagram clearly indicates that 1 month after CTRT and 3 months, we have a clear-cut decrease in size of the lesion, showing a wonderful effect of CTRT. So one of the last few slides, we all know about LAURA trial. So after the completion of CTRT, if EGFR is positive, then we give osimertinib. So the point of discussion here I want to ask you, Dr. Ashish, is in ADAURA, we give osimertinib for 3 years. We have talked about the later chance of recurrence, the steep down curve of after 36 months, Dr. Minith has said. But in LAURA, we give it until progression. Why do you find there is such a discrepancy in it? Anything you want to comment?
Of course, we know that after surgery, the status is R0, the tumor is not there. But post CTRT, the disease is still there. Many times we see even partial response or stable disease. So if you can talk about when to stop osimertinib, maybe would you consider stopping after 3 years? Then the answer would be yes. In those patients who are seen who's showing complete response on PET scan, ctDNA is negative, and the patient is having side effects. In those patients, I can even discontinue after 3 years.
Sir, apologies. We'll just wait for a minute. Sir has logged out.
So sorry, my just the laptop got hanged. So sorry for the interruption. I'll again share my slide. Just a minute. The last few slides are left. Am I audible? I hope.
Yes, sir.
I'm so sorry for the inconvenience. Yeah. So I think I heard Dr. Ashish, and so I think this is now Dr. Minit. Are you there?
Yes, I'm there.
So,
Yes.
so yeah. Sorry, I would again want to hear from you that 3 years versus until progression data in both the
No,
cases.
I do agree what was said by the earlier speaker that a post-surgery and a post-chemoradiation setting is a different ballgame altogether. And stage 3B, 3C disease is not a good disease to deal with. It is almost similar to having a stage 4 disease. And I think probably they learned from the ADAURA experience. And it was the best thing to do is to continue till progression. I do agree with whatever they've designed or whatever changes they've made in LAURA as compared to ADAURA.
Okay. So, like the last few quick 5 questions. Dr. Ashish, do you consider consolidation therapy for all your patients?
Yes.
Okay. Dr. Minit?
Yes, all patients and as per the driver mutation status. So no EGFR, no ALK, immuno. If there is, then you give accordingly.
Dr. Gautam, as a part of FDT, do you agree with it?
Yes,
Dr.
absolutely.
Hemant?
Yes, sir.
Okay. So, when do you decide to add at the start of therapy or post CTRT? Dr. Minit?
Post chemo radiation. So we don't. So there are a number of sequences that they plan during in stage 3 neoadjuvant along with CTRT and post. But we are usually following definitive chemo radiation followed by like post CTRT consolidation. We are not giving it before it or during it.
Agree. Dr. Gautam, do you think that any radiation toxicity would hamper the use of any consolidative or TKI therapy? Have you seen such cases that because of that, the TKI would have been delayed or the toxicity would have been added?
Usually not, but after like 6 weeks of chemo radiation, usually the patient uh, they recover from the radiation toxicities.
Okay. So that's why the next question is how long do you wait before initiating consolidation therapy post CTRT?
So
Dr. Ashish?
in case like some people develop some grade 3 or grade 2, in grade 2 we'll wait for some time, like maybe 2 to 4 weeks more, so that the toxicity comes down to grade 1. And if the patient is experiencing grade 3, so we won't be starting.
Okay. Yeah, Dr. Ashish, you want to say something?
So basically, within 4 to 6 weeks, I would be starting. If the patient is having symptomatic pneumonitis, then I'll wait for the pneumonitis to resolve to at least grade 1.
Dr. Minit, any cases exhibiting osimertinib post pneumonitis grade 1, grade 2 by osimertinib?
Uh, so especially this patient who has already a baseline poor lung field. So these are the patients or those who have baseline ILD or those who have these baseline bad lungs in the form of bronchiectatic or chronic bronchitis, emphysema, bulle. So these are the patients who eventually end up getting these lung toxicities as well. But most importantly is that the Pacific trial had 42-day cutoff. So usually we assess 4 to 6 weeks post completion of chemo radiation. Pneumonitis grade 1 was allowed even in that trial. Anything above grade 1 is we need to wait for at least the pneumonitis to resolve and at least to know whether anything is reversible or no.
Dr. Gautam, whenever there is a radiation-induced pneumonitis, we all know how to manage grade 1, grade 2. Do you think a chest physician becomes an important part of MDT in
Surely,
that setting?
surely.
Yeah. Dr. Minit, do you
Sorry.
involve?
So,
The chest physician is a part of MDT?
yes. So chest physician is a part of our MDT and they see almost all of our patients post chemo radiation. So they're actively
Yeah.
involved in our MDT program.
Yes.
And Dr. Ashish and Dr. Hemant, do you agree with it?
Yes, sir. Yes, sir. Because the dose of steroids also need to be up and down. So definitely, pulmonologist is a must.
Okay. So I think the last question of indefinite therapy we have already discussed. Just a quick point. If there is a progression of disease in adjuvant osimertinib and the DFI is around 11 to 12 months, you have done the repeat biopsy, NGS is again EGFR exon 19 deletion. The progression of the disease is either local or metastatic, and DFI is around 11 to 12 months. Your choice is repeat TKI, chemo, or amivantamab. Anybody wants to comment on amivantamab?
Yeah, so in this, so I think we're talking about LAURA. So LAURA will not have a DFI technically. So LAURA will be like on osimertinib progression.
No, I am talking about ADAURA also.
Oh,
Both.
ADAURA
Any
also. Okay,
condition.
Sorry,
Yeah.
sorry. Okay.
Yeah.
So I think the same is what I said earlier. So what did you say DFI is? How many months? Sorry.
11 to 12 months.
Okay, so rechallenging repeat biopsy definitely we do for all our patients of driver mutation is
Yeah, that has been done.
yeah, that has been done. And you said there is only EGFR exon 19 and no other mutation.
Same.
So rechallenging a TKI with chemotherapy would be one of my options. Considering a 1 year DFI. But frankly saying amivantamab, not a bad choice. Not a bad choice. If the patient is, if financial constraints are not there, then not a bad choice for giving amivantamab plus chemo. But rechallenging osimertinib will definitely come on the table if the DFI is 1 year.
Dr. Ashish.
I agree with that. Along with that, biology also plays a very important role here. If there is MET amplification, then definitely amivantamab can be a good option. Or if there is only T790M, then maybe again we can start with OC or plus minus chemotherapy. So biology becomes a very important part over there.
Okay. So I think we have discussed pretty much, and this is my last slide of managing of pneumonitis. So we all know that grade 1 no dose modification of osimertinib is required. For grade 2, hold study drug until resolution of symptom, and we can reinitiate at 80 mg. And for grade 3, if symptoms have not resolved within 4 weeks after interrupting study treatment, and if it is gone to, again, it is grade 3 or grade 4, then we have to permanently discontinue the drug. So I would like to thank all my panelists, Dr. Hemant, Dr. Ashish, Dr. Minit, and Dr. Gautam for your valuable time. And thank you, Astra, for giving me the opportunity to have a wonderful discussion tonight. Thank you so much.
Thank you, sir. Thank you all.
Thank you.
Thank you, sir. Now I would like to invite again Dr. Sanjay Rai for the closing remarks. So over to you.
Yeah, thank you everyone. My sincere gratitude to all speakers and panelists along with the sponsors. And it has been a fruitful webinar today, and it will certainly help to improve our lung cancer care, which will benefit ultimately to our patients. Thank you very much.